Good evening, everyone, and welcome to Wednesday Wellness, a free live educational series by Trinity Health. We're thrilled that you have joined us this evening for the important topic of advancing lung cancer diagnosis with Ion Robot. Before we started, we do have a few housekeeping notes we'd like to share with you. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, we ask that you use the Q&A chat feature, which is located near the bottom of your screen, and questions will be addressed at the end of the presentation. Lastly, today's webinar is being recorded, and we will share a link to that recording with you over the next several days via email. And without further ado, I am pleased to introduce pulmonologist Dr. Eric Geiser with Trinity Health Medical Group.
Hi, everyone. Just wanted to introduce myself. My name's Eric Geiser. I'm a pulmonary critical care physician at Trinity Health. I grew up in upstate New York, and then I did my training in internal medicine in Birmingham, Alabama. Then I did a fellowship in pulmonary critical care in San Francisco. I met my wife out there, who's from the east side of the state, and then we moved here in 2013. I just wanted to thank everyone for coming to this program. This is something that I'm super interested in, and a field that's really changed dramatically over the last decade, even since I completed my training back in 2009. So I'm going to sort of break this talk up into two pieces. You know, it's hard to talk about a diagnostic procedure if we don't talk a little bit about lung cancer and just the underlying disease. And so in terms of lung cancer, we've known about lung cancer probably since the mid-19th century. The original descriptions sort of go back to, the 1850s or so, where people thought that this was a rare disease, didn't really think too much about it, wasn't sure what it was going to become in the future, but definitely things have changed quite a bit. So currently, lung cancer is the #1 cause of cancer-related death in the world. Probably one thing that really sort of made lung cancer move from being a rare disease to a more common disease was really the advent of smoking tobacco. In 2022, lung cancer was accountable for about 1.8 million deaths worldwide. And as everybody sort of keeps track of different cancers, overall, we're now #1 in terms of cancer deaths for both men and women. And in terms of new cancer cases overall, we're second to prostate in men and then breast cancer in women. For the purposes of this talk, lung cancer definitely has different subtypes. But to try to keep us on track and not go through a lot of extra detail, I'm just going to refer to lung cancer as one disease, though there are different subtypes to be aware of. So what's made lung cancer so challenging for us as physicians? So compared to other cancers that we know about, really patients who come and see us, they don't have a lot of symptoms. Usually when we're finding lung cancer, it's because someone had a scan for some reason, and we incidentally found a spot in their lung or something that looked abnormal, which led us down this pathway. Lung cancer, unfortunately, until you have fairly advanced disease, doesn't give you a lot of symptoms. It's not like, say, skin cancer, where you can see something on your skin. It's not a very painful disease until it's fairly progressed. It doesn't necessarily cause symptoms of shortness of breath. And so it's hard for people to know, is this something that's concerning for them or not until they get some form of imaging study along the way. One of the things that we've learned over time is, as you all know, we linked cigarette smoking to increasing your risk of lung cancer significantly. The Surgeon General had put out the first warning back in the 1960s, where lung cancer sort of really took off because of how much smoking was going on. Despite everything we've done to understand that relationship between lung cancer and smoking, we still struggle to try to curb smoking. And so around 28.8 million Americans continue to smoke, looking back in 2022. And then smoking, when you look at it in general compared to causes of preventable disease, it's the leading cause of preventable disease and of death in the US. We've looked at a bunch of different things over the years to try to find lung cancer and to find lung cancer earlier rather than later. And it wasn't really until 2010, when we did the National Lung Health Study, that we really had a diagnostic test that could find the disease. We've looked into blood tests prior to CT imaging being as available as it is today. We did a number of X-ray studies looking at smokers and non-smokers, and we didn't really find disease any earlier. We found more disease, but unfortunately, we found it at a really late stage, where there wasn't much that we could do in terms of therapy. As we look at how to diagnose lung cancer, and we'll talk about that a little bit further in the talk, but the original ways were pretty invasive. We had X-rays to guide us, but then most of the time, in terms of doing a biopsy, we were limited in terms of talking to one of our surgical colleagues and saying, hey, I think we just need to cut this out, which is a very invasive procedure with definitely significant complications. And so we've been looking for this more minimally invasive way to diagnose lung cancer and find it at an early stage. When we think about lung cancer overall, we're usually talking about something developing as a very small spot in the lung. And when most people hear from their doctor that they have a spot, or an organ looks abnormal on something like a CT scan, we all think the worst. We think, hey, I have cancer, until someone tells me that I don't. But only about 30% of, if we just scanned everybody, would have some pulmonary nodules in their lung, but not all of those are going to be cancerous. So part of our job as physicians is to try to figure out, which ones of those are benign disease, which one of those are malignant, how do we prove that it's malignant, and then what are going to be our next steps in terms of treatment. So of those people that have nodules, only about 10% of nodules are concerning in terms of their features or their risk to be a disease that we need to treat. And then about 2 to 3% of nodules are something cancerous. And we'll come back and talk a little bit more about this further in the presentation. What we know about lung cancer is similar to other cancers that you might have heard of. We do divide cancer into stages, and definitely early stages better in terms of treatment, as well as cure and survival. When we talk about lung cancer stages, stage, just to try to keep it simplistic for all of us, stage 1 is a localized disease. So this is like a small nodule in your lung. Typically, it's not going to involve things like lymph nodes, and it's not going to spread to other organ systems. Stage 4 disease means that it's spread outside the lung or to other tissues. So just looking at, this is sort of an older slide from back in 2017, but you can see that people with early stage disease have a much longer 5-year survival compared to people with late stage disease. If we look at a little bit newer data, this comes to us from the National Cancer Institute. They chose not to necessarily break it down based on stage, but more something that people have a better grasp of, to just say localized, meaning confined to one chest, regional, confined to the lungs, or distant disease. As I mentioned before, we do break this out a little bit in terms of what's called non-small cell lung cancer, which is the more common type and more associated with smoking, versus small cell lung cancer. But you can see, regardless of which type of cancer you have, you do much better in terms of survival if you have localized disease. And that's why we've worked really hard to try to figure out, diagnostic procedures that can try to get us better answers earlier, that can give us all of the information that we need. So what's changed in lung cancer? So we talked about some of the changes that have occurred. And so we've moved from chest x-rays, which really couldn't pick up some of these small nodules that we're trying to see, to CT imaging, which is now readily available. And then now we have lung cancer screening. So being able to perform CTs for people that are more high risk. So those are smokers or former smokers age 50 to 80 with more than a 20-pack year history of smoking, who have quit within the last 15 years or are still smoking at this time. As we're going to talk about a little bit later in the talk, definitely we have better diagnostic techniques than we had before that are less invasive, that can catch earlier disease. We talked a little bit about lung screening already, and then treatments changed significantly. So years ago, if you thought about lung cancer treatment, people talked about surgery for those people that had localized disease, or chemotherapy. And initial chemotherapy was what most of us refer to as cytotoxic therapy, which means that we gave individuals or patients a treatment that not only killed cancer cells, but also killed normal living cells, which caused a lot of side effects for many people. And we've definitely moved forward in that era, where when we're doing diagnostic procedures or biopsies to prove that someone has a cancerous tumor, we're looking at sort of a molecular signature of that cancer to use what's called immune therapy. And so that's using natural components of our immune system to help fight the cancerous lesion. And so it's attacking those cancer cells specifically without destroying any of the normal tissue. So the side effect profile is a lot better, and your survival is a lot better when we can identify those things on a tumor that can help determine your treatment. When we talk about ways to diagnose lung cancer, biopsy still remains the gold standard. Similar to other cancers, we've looked at laboratory testing, and it's just sort of not prime time yet. But we're still going to continue to look for less and less invasive techniques. As I talked about earlier, in the past, we talked to surgeons. The way we diagnosed lung cancer was we'd have an x-ray or a CT scan that showed a spot in your lung. If we thought it was something concerning, then you'd end up with what was called a thoracotomy, where you had a large incision in your chest. They spread your ribs, and then they would remove the lesion. And sometimes we removed lesions that were benign because we thought that they were cancerous, which we definitely want to try to avoid. Sometimes we diagnose malignant disease, but it wasn't necessarily just localized to that area. And so the goal of all of the newer diagnostic techniques, which we're going to go through, is really to identify a cancer, make sure that we're going to come up with the right treatment plan, and try to reduce your risk of complications. When we talk about lung cancer, one of the things that we worry about is whether it's been spread to lymph nodes within your chest, because that changes your staging. Similar to the surgical approaches, we used to use a procedure called mediastinoscopy, which even many of our thoracic surgeons don't do anymore, because newer and better techniques are available. When you talk about approaching lung cancers rather than cutting through the chest, the next idea that sort of came up was what was called bronchoscopy. So approaching areas in your lung that looked abnormal, by taking a camera, just like a colonoscopy. Um, the advantage of this technique is we're going through your natural airways. We're not needing to go through your chest wall or around nerves, which could cause you pain in the future. And initially, we had a tool called the fiber optic bronchoscope. Basically, this is a camera on a flexible tube that goes typically through your nose or through your mouth. It goes down into your lungs to where we think the lesion was. Before robotic bronchoscopy became available, the way that we tried to biopsy lesions or nodules in the lung was basically by X-ray imaging. And so the yield of this procedure wasn't as good as we hoped. There's probably more than one reason why that occurred, but when you talk about the yield from the procedure or obtaining the diagnosis, it was really only around 70%. When we biopsy lung tissue, there's always a chance of what's called a lung collapse or a pneumothorax, and that's around 6%. When we were doing this with X-ray studies, part of the limitation was we were really looking at a two-dimensional image as opposed to something in 3 dimensions. And I think that probably contributed significantly, to the diagnostic yield. Fortunately, with the new technology that we have here at Trinity Health, we're now using a CT scan image. We're using a special map, which I'll explain how we construct that in the robotic bronchoscopy, but that allows us to have that true 3-dimensional image. It allows us to look at it in real time. One of the difficulties when you think about biopsying the lung compared to other organs is the lung moves. It's not like biopsying something on your skin or biopsying, a muscle or biopsying your liver. It moves and it has to continue to move. That's part of what keeps us alive. As people tried to move away from doing thoracotomies, to diagnose lung nodules or cancerous lesions in the lung, we started to use our radiology colleagues. And so, similar to the robotic bronchoscopy, they were using CT scans to try to biopsy lung lesions. But similar to that true surgical approach, they're still going through the chest wall. Sometimes they have to go through some lung. So the risk of a tear in the lung or a lung collapse was pretty high, and still, even with experienced users, is around 20 to 30%. Our newer technology, which we're going to get into in a minute here, has a risk of lung collapse probably closer to 3%. As technology evolved, pre-robotic bronchoscopy, we had a little bit better technology called navigational bronchoscopy, which was better than that fiber optic bronchoscopy with X-rays, but still didn't quite meet where we wanted to be in terms of diagnostic yield. though the pneumothorax rate was much lower than an IR-guided type of procedure. These are some of the tools that we've used over time. The first one is probably a tool I would never want anybody to use on me. But this was the first bronchoscope that we ever had. Basically, it was a rigid device. It was designed really to just look in your trachea or your main airways and used mostly to remove foreign bodies. But as I'll show you on some of the CT scans that we're going to look at here in a second, many of these lesions in the lung that are cancerous or precancerous that we're interested in, they're pretty far out in the periphery of the lung. So these older tools that just allowed us to look at central lesions really weren't very helpful. Fortunately, as you can see in the photos, in the second one from the left, you'll see sort of our modern day bronchoscope, which is flexible. It has a camera on the end. It has the ability to suction. It has the ability to place tools through the camera, which allows us to do things like biopsies, suction secretions to look for infection. The next tool came out actually during my fellowship time. And this, what it did was, in addition to that flexible camera, what we did was we added an ultrasound on the end. And so beyond having the ability to get further out in the outer areas of the lung, this also allowed us to sample some of the lymph nodes in the chest. So this has really replaced mediastinoscopy as part of one of the tools that we use when we're trying to not only diagnose lung cancer, but we're also trying to determine the stage in the same procedure. So that way we can get you closer to treatment without any delays. The next picture that you see, this is the fourth one. This was the initial, what was called navigational bronchoscopy. So again, this got us further out into the lung, but we still didn't have that true 3D image. We weren't able to correct for things like movement of the lung, but was definitely a big step forward in terms of what we were able to do. This slide just sort of talks about the evolution of the bronchoscope. Robotic bronchoscopy, which is the main focus of our talk here today, started to develop around probably 2017. People were starting to talk about it. The first platform came out in 2018. And then here at Trinity Health, the platform that we're using is something called the Ion robot. It's very different than sort of the robot that many people think of. It's not something that, does everything by itself. It's not something that stands alone. It still needs that physician interface to be able to use the tool. As you think about robotic bronchoscopy, we're actually learning a lot from many of the gamers out there, and two of the robots that are currently available, actually, people that play video games helped us design the equipment to make it user-friendly, but still achieve the purpose that we're trying to achieve. So this is what we currently have at Trinity Health. It's what's called the Ion robot. So what happens during the procedure is we take your CT scan, we load that into the robot. The physician who's performing the procedure sits at this console and uses the robot, which is on this scaffold, as you see, and that gets advanced into your airway. Here at Trinity Health Grand Rapids, we were really fortunate that in terms of pulmonary procedures, we have a dedicated procedural suite. We not only perform our robotic bronchoscopies in this suite, but also our more traditional bronchoscopies with the help of our team. So what happens when we find a nodule in the lung? So typically, your primary care provider or the ER will refer you to either a pulmonologist or a thoracic surgeon who will have a visit with you in the office. And during that visit, we're trying to figure out a number of things. We're definitely going to review the scans and whether we think that that's a concerning spot in your lung or not. Things that we take into account are your family history of cigarette smoking, history of other exposures, or things that would increase your baseline risk of a cancerous nodule. The other thing that we evaluate as we're looking at CT scans is, what does that nodule look like? Is it something that we have prior studies to compare to and it's not growing or changing? Is it something that's irregular or spiculated? Is it distorting the actual architecture of your lung? Is there just one lesion in the lung, or are there more lesions in the lung? Are there enlarged lymph nodes? We take all of those things into account when we're trying to figure out what's the best procedure for you that's going to provide us with a diagnosis that's going to move you on to treatment, reduce the complications in that way. As we take your CT, once we've decided that this is a nodule or a spot in the lung that we're concerned may be cancerous, we load that into the software package of the Ion robot, and basically it creates a virtual tree for us. So this is what the computer generates from your CT scan that it assumes we're going to see in real life when we put the camera into your airways and into your lungs. And so similar to, say, GPS in your car or MapQuest or other technologies like that, that's what the Ion Robot platform does for us. The other nice feature of it is that it can identify other anatomic structures that we might want to stay away from, things like blood vessels. The lung on the outside is surrounded by what I call a saran wrap, which gives it its structure, which is called the pleura. Definitely we want to try to stay away from that area because that's where your risk of a lung collapse comes from. And so if you look at the image here, you can see there's sort of this purple structure towards the outside of what your lung would be, and that marks the pleural line for us. The nice thing about the technology is, it also tells us how close or how far we are from the lesion. It can tell us how far we are from that anatomy border that we're trying to avoid. The other piece of this procedure, as I mentioned, that we fortunately have here at Trinity Health, is basically it's like a portable CT scanner. It's called the CEOS device. And so what that does for us is, even if we think we're really close to the nodule, sometimes we're just not entirely confident. So during the procedure, we can actually do a CT scan. We can look exactly where that camera is, make sure that if we're putting a biopsy forceps in, or we're putting a needle in, that we're truly in that lesion of interest, to make sure that we're standing the greatest chance to give you an answer as to why that nodule is there. This is sort of the next phase after we look at what's called the airway tree, which is really a diagram of your airways, followed by the smaller airways or the bronchi, which go out to the nodules. And then, as you can see, this is the map that it creates for us. So it tells us whether we need to turn up, turn down, go left or right to make sure that we're in the right airway and headed towards the lesion. Once we get to the lesion, basically it looks like this round ball. We use a technology called ultrasound, which shows us the lung tissue as well as the nodule itself. And that makes us confident that we're in the area of interest rather than being in normal lung. The nice thing about the procedure compared to doing thoracotomies years ago is that this is a totally outpatient procedure similar to a colonoscopy or an endoscopy. We do perform the procedure under general anesthesia, so you are completely out during the event. It's not a painful procedure, so experiencing pain would be very unlikely. Procedure we typically schedule for about an hour and a half. In terms of how much time it truly takes, a lot depends on the size of the lesion. Larger lesions are easier to reach, or if they're more central lesions versus smaller lesions that may be further out in the periphery of the lung, sometimes take more time, or if they're in areas close to the heart or the diaphragm, where we want to make sure that we're not going to injure one of those structures. Start to stop, including your check-in and check-out, it probably takes around 3 hours. We do ask patients to have a driver because you will be under general anesthesia, and we don't want you to drive home. As I mentioned, it's generally a painless procedure. The main risks of the procedure itself are really bleeding because we're cutting into lung tissue, infection because there's natural bacterium that lives in your airways, which we may stir up. So that's something that we watch out for. And then what I mentioned before, a pneumothorax or a lung collapse. Sometimes, even though that sounds like a very scary event, sometimes it's just a small tear. We may monitor it by x-rays. We may keep you in the hospital for a day or two to make sure that it's not worsening. The lung's pretty resilient overall, so the lung will heal itself. But sometimes when someone has a larger lung collapse, we do ask our surgeons or our radiologists to place a small tube in the chest, which allows the lung to re-expand, and then the lung heals itself, usually within 2 or 3 days. Sometimes it's shorter than that, depending on the size of the tear. But usually it's not something that we need another operation to try to fix. As I mentioned before, the real goal of looking at cancer is doing a procedure that not only gives you your diagnosis, but gives you the staging, gives you the molecular signature, if something like chemotherapy, immunotherapy, or other modalities are needed to make sure that we're really targeting the cancer that we see if the nodule does turn out to be cancerous. We do an x-ray after the procedure, as well as a survey of your lungs to make sure that there's no significant complications. And then if your oxygen level looks good, your blood pressure looks good, and you're awake, you go home that same day. A little bit of data about our program, and then we'll be able to finish up and you'll be able to ask questions. We do these procedures both here at Trinity Health Grand Rapids as well as our Muskegon partners out on the lakeshore. So if you don't live here in the Grand Rapids metro area, there are other Trinity facilities where this is being done. Currently in Grand Rapids, we have 4 providers that are doing this procedure. It includes myself, Dr. Harris, Dr. Prest, and then Dr. Shabahang, who's one of our thoracic surgeons. And then we can't do this without our staff and our nursing team. Some of them have gone for the training on the robot itself with us to gain more experience and make sure that they can really help us through the procedure. But because this isn't something that we can do on our own, we need our nurses, we need our anesthesia colleagues. So it does take a whole team. And then, so this is sort of the latest data. We're still collecting data for 2025 as we're not quite here at year end yet. But definitely in terms of lung cancer diagnoses, as we've gotten this new technology, is we're doing a great job trying to find those stage 1 lung cancer patients for either surgery, radiation therapy, or chemotherapy stands a chance for cure. We still find some people with late stage disease, unfortunately, but we're still able to offer them some therapy to try to prolong their life, which we get from this procedure. And then this just looks at number of lung cancers diagnosed per year. We'll see, I think we're doing more procedures here in 2025 as we're identifying more patients that potentially have lung cancer. We have 2 major programs here at Trinity Health Grand Rapids that do that for us. We've had a lung cancer screening program for quite a long period of time, probably at least 4 to 5 years. And then the other program we have to try to find nodules that may be cancerous is a program called FIND. And so what that does is basically there's a nurse coordinator who's looking at all the studies done throughout our facilities, whether it's CT scans, whether it's x-rays, MRIs, ultrasounds, to try to pick up any of these concerning nodules so that we can try to get people diagnosed if they do have cancer and get them on the appropriate pathway to treatment. So we've been doing robotic bronchoscopy here. I think we started in September of 2023. We've done roughly 300 cases so far. Our complication rate, as we were hoping, has stayed relatively low at around that 3 to 4% range. And we've been able to obtain the specimens that we need to determine the next steps in terms of treatment. We do have a dedicated nodule clinic, which we run through our pulmonary office. In terms of getting patients seen from their initial diagnostic study, which showed a spot in their lung or a nodule, we try to get those people in within a week. We try, if they do need a procedure, we try to get that done within 2 to 3 weeks. We meet both as a team pre-procedure to try to figure out exactly what procedure is the most appropriate. Then if it is a cancerous lesion, we do bring that back to our tumor board as well as that initial team to figure out what your next steps are in terms of treatment. And then usually most of that's done within a week of the procedure. And we then coordinate any referrals or any other needs in terms of what your treatment will be. Just wanted to thank everyone for attending this presentation today, and we're open to questions.
Yes, thank you so much, Dr. Geiser. That was an excellent presentation, very informative. We do have a few questions that we've had submitted. And so I'm just going to jump right into those. And if you could answer them, that would be great. These first couple, I think you actually just touched on a couple of them. The first one is, do you need a referral if you would like to be considered for the CT lung or the ion procedure?
Yeah, so for CT for lung screening, you don't necessarily need a referral to pulmonary specifically. Any of the primary care physicians can take care of that for you. And we're just trying to put out a lot of education about what those initial criteria are in terms of pack years of smoking, age, and then whether you've quit smoking or you're still smoking. You can get into that program pretty easily. And
Thank you.
then what was the second question?
The second one is if somebody is interested in learning more about qualifications for the ion procedure, would they need a referral to your office?
Right. So, either the pulmonary office would be a great place to start. Dr. Shabahang, who's one of our thoracic surgeons, does do this procedure as well. So either of those avenues, if you have a nodule or a spot in your lung, or you have a patient that's concerned, we're more than happy to see them. And if an ion or a robotic bronchoscopy is what they need, then we'll walk them through that process.
Thank you. This next question I think would be a good follow-up for that CT lung. And it is, are there other qualifying factors besides smoking that would allow you to qualify for a CT lung?
Yeah, so right now, lung screening's based on smoking alone. And it's interesting because, we talk about pack years, and there's definitely people that are younger that probably have the pack years smoking, which would increase their risk. But because they're less than 50, they don't necessarily qualify. Sometimes, if people have specific symptoms, then that may be a way to get a CT scan done. I do wish certain other things, asbestos is something you hear a lot about. And I'm not sure that asbestos alone will get you a CT scan. Years ago, they used to have special x-rays to do that, but definitely CT scans would be better. So it really depends if there's any symptoms that can drive it to get it done beyond just smoking alone.
Thank you so much. These next couple questions look like they're specific, a little more specific to the procedure, including how soon will you get results after the ion procedure?
Yeah, so I usually say 3 to 5 business days. Typically, we're doing procedures on Mondays and Thursdays. So if you're done on Monday, provided that there's nothing like a holiday that falls in the middle, usually we're able to give you a result, say, by Wednesday. If it's done on Thursday, we usually have results the following Monday. We try to communicate results, with the expanse of technology and patients wanting to know the answer right away. We try to call you with those results as soon as we're able to look at them, because if you've had a biopsy, and you've waited a little bit already because somebody told you a spot, that anxiety can be really, tough to manage while you're just waiting for your result. Sometimes we do bring people in for a visit to discuss the results. As we get to know you, then we can sort of gauge what the best way is for us to deliver that information.
Thank you. The next question was, are the screenings and procedures covered by most insurances?
Yeah, so screening is covered by most insurances and specifically for Medicare, for sure. It took a little bit of time from the original study to get them on board, but that really hasn't been an issue for us.
Thank you. The next question is, I know this was not the focus of the talk, but could you quickly go over what the subtypes of lung cancer are?
Yeah, so as I said, if you break down the first two major subtypes, we talk about non-small cell lung cancer, which is the most common type as well. And then the other major type is small cell lung cancer. When you start to break down non-small cell lung cancer, we talk about adeno, we talk about squamous, and each of them and large cell, and they all behave a little bit differently. Sometimes we use that analysis, which helps guide your treatment as well.
Thank you so much. The next question is, I've heard a lot about radon being a cause of lung cancer. Is this true, and what risk is that?
Yeah, there's probably an association for sure. I don't know the exact data to totally answer your question. In term, as you know, if you're buying a house, sometimes they'll check radon levels, and at a certain level, you have to have a special device that helps eliminate that radon from your house to reduce your risk. But I can look further into that to give you more specific numbers.
Thank you so much. The next question is, with the increase of pot smoking, will we see an increase of lung cancer? How many years of smoking until someone might see lung cancer?
Yeah, that's an interesting question, and another piece of that question comes to things like emphysema or COPD. Definitely, we know that if you smoke cigarettes and you're smoking marijuana, that your risk of COPD is much higher than having either habit alone. I don't know that we have a specific causal link to marijuana smoke, but when you think about, smoke or air pollution, the lungs, in terms of their exposure to the external environment, is probably the largest organ exposure outside of your skin that we know. And so your lungs are filtering all of these things all the time, and anything foreign to the lungs or to the body that hasn't been filtered, has a chance that it could change sort of the cellular makeup, which could provoke a cancerous lesion. But I don't think that there's been a causal link to marijuana specifically at this time. But definitely we know that that's true in terms of tobacco.
Thank you so much. This one looks like it is our last question. Dr. Geiser, could you go through how long the actual procedure takes?
Yeah, so usually we do those procedures in our endoscopy area. So typically patients come about an hour prior to their procedure. That's where you get registered by the nurse. They take your vitals. You'll meet anesthesia. They'll go over what that general anesthetic looks like, make sure that you don't have any questions, go over your history of any problems with anesthesia in the past to make sure that we're keeping you safe during the procedure. Then once the procedure starts, as I said, it usually takes about an hour to an hour and 30 minutes. Then after the biopsy is completed, then patients recover in our surgical unit. Once their blood pressure and their vital signs look good, then they come back to our endoscopy area where we finish, I would say another maybe 20 minutes of recovery. Make sure that you're awake, make sure that you can eat and drink, and then you're ready to go home.
All right. Thank you so much. It looks like we have made it through all of our questions. So thank you so much, Dr. Geiser, for the excellent Q&A and the great presentation. We would like to also thank, as Dr. Geiser mentioned earlier, thank you so much to everyone who joined us this evening. And we hope you have a great rest of your week.
All right. You guys have a good night.